Olá a todos, então bem-vindos a mais uma Osteotalk. Desta vez vou estar com o Dr. Eyal Lederman, acho que não precisa de apresentações, DO, PhD, e vamos falar sobre o seu novo livro, Prescrição de Exercício Funcional. É o tema da Osteotalk e é também o tema do seu novo livro. Vou só apresentar o Dr. Eyal Lederman muito brevemente. O professor Eyal Lederman é graduado pela British School of Osteopathy, a antiga, atualmente a UCO, é o diretor do CPDO, é um centro, uma plataforma, uma empresa de desenvolvimento profissional contínuo na área da terapia manual, osteopatia, fisioterapia, e tem um doutoramento, PhD, pela King's College em Londres e investigou a neurofisiologia da terapia manual. Também desenvolveu e investigou as Osteopathic Harmonic Technique, as Osteopathic Functional Neuromuscular Rehabilitation e a Osteopathic Functional Stretching. De resto são nomes dos livros do próprio professor. É professor honorário da University College London no Instituto de Orthopedics and Musculoskeletal Science, onde investiga e ensina também esta reabilitação funcional. Publicou vários livros, Harmonic Technique, já da década de 80, Fundamentals of Manual Therapy, The Science and Practice of Manual Therapy, Neuromuscular Rehabilitation in Manual and Physical Therapy, Therapeutic Stretching Towards a Functional Approach, e o seu último livro, que dá o tema ao podcast, em 2022, este ano, Functional Exercise Prescription, Supporting Rehabilitation in Movement and Sport. E é autor de vários artigos também, de vários papers. The Fall of the Postural Structural Biomechanical Module in Manual and Physical Therapies, em 2011. Estava a dizer agora ao professor que é uma das referências, este paper, uma das referências, pelo menos comigo, nas aulas, onde este pensamento outside the box começou já há mais de uma década. A Process Approach in Osteopathy, Beyond the Structural Model, sei também pelo IJOM, em 2016, em 2017, a continuidade desta ideia de um pensamento fora da caixa, no sentido, fora do modelo puramente biomecânico e estrutural. De resto, as referências, the references are going to be available online, on YouTube and on our platforms, nas nossas plataformas. So basically, I did an introduction of you, Professor. Thank you so much for
the gist of it.
Thank you so much for accepting the invitation.
And thank you for inviting me.
Oh, it's a
Osteoform.
It's a pleasure. It's a pleasure. So I have we have kind of an informal talk. We have also a PowerPoint presentation of your book, if you want. I just have a couple of more broad. General questions.
I'll do it as you instruct me. You decide what is best for you.
Okay.
I've got different options here.
Yeah.
Let's see where we go.
Let's see where it goes. So I was explaining in Portuguese as you're one of the authors I very often refer to when I'm talking to students, second, third grade students, because you've been. I mean, you started writing books since the 1980s. I think it was your first book with harmonics, but your
Yes.
papers criticizing the pure structural biomechanical model has been more than 10 years now.
Yes.
And if we could go back 10 years or more, you've been criticizing these biomechanical structural models, and it's still very, very it's still very present, this criticism in many osteopaths, more and more researchers and osteopaths, this call for review, rethink, reconceptualize models that are used in osteopathy and manual therapy and even physiotherapy, because there's still kind of, there's still a lot of teaching about what's posterior, anterior, frontwards, backwards, how the posture is. And the more we know about physiology and neurosciences and even biomechanics, the less importance it's given scientifically to this type of things.
Yes. I mean, we know, for example, that biomechanics, there are no known conditions caused by faulty biomechanics in medicine. There just isn't, unless a person is severely has structural problems like, scoliosis, where they are actually disabled in a wheelchair.
Yeah.
Most normal individuals that have biomechanical misalignments and all that, we've been trying to look for it for the last 30, 40 years, the connection between those and human suffering. And we can't, it's not there.
Yeah.
So maybe we need to stop looking and, start reconceptualizing it, as you said. And build a different model that more suitable and more modern.
Yeah.
A lot of osteopathy is historical. It's we teach osteopathy like as if it's a museum piece. We did this so long, and this is in the museum. Then it must be osteopathy, and that's the only way to do it. And osteopathy can be exciting and new, and provide new tools and increase the spectrum of work that we can do with different conditions that we don't usually, like yourself, probably working with neurological conditions that is not taught in osteopathy. There's no neurology in osteopathy.
Yeah.
Absolutely zero.
Yeah.
And that affects all rehabilitation work and exercise work and all that, which depends on neurophysiology. It's just not there.
I can't remember the paper exactly, but there was a very interesting paper not many years ago in biomechanics that they could not find a relation between a functional valgus knee and a mechanical axis of the femur and the hip in runners. So someone with an increased functional valgus knee did not have or did not experience more hip pain or knee pain in athletes in running. So they could not make a connection between, different momentum torques, different Newton forces, in more valgus or less valgus in runners.
Yes.
So it's
it's all around us. I mean, even think of something simple in your daily activity. We all wear heels in our shoes to some extent, a slightly raised heel. And it's not natural. We changed the whole biomechanics of the foot wearing shoes.
That's very true.
We changed completely our posture. Our gait is probably changed. The force is going through our body. Now you would think that by a certain age, we would fall apart because of these abnormal mechanical forces, but nothing happens because there is a lot of tolerance in the body. It's built in this excess that we can take, the body can take without any problem. And that's why, it's contentious, but women who wear high heels don't really have more back problems or more hip problems or more knee problems than anybody else, although they are biomechanically in a very disadvantageous state.
Yeah.
So it's all around us, this lack of relationship.
And I talked about this with Dr. Stevers a few weeks ago, and it's also something I talk about a lot in my teaching. Is even a guy in 1991, I think, a construction worker, he stepped on an iron metal, how do you call that, nail,
yes,
through his foot, through his
yes,
boot.
I remember that story. Yes, it was very famous.
A lot of pain, excruciating pain, and no injuries. Not even the skin got It's amazing. Yeah.
So our brain can regulate our pain experiences in a big way.
Yeah.
Overriding the physical aspect of pain. So, if necessary, depends on the situation, of course.
And the more we know, it's like we really need to bring the patient, the active patient. We really need to bring activity. George Steves and Francisco Saritelli talk about active inference in activism, but we can talk about moving the patient, putting in normal daily activities, as you say, like in functional therapy. Like the patient really needs to be involved in his therapy, and not just lay down on the table and we do a manipulation of the iliac, and that's kind of the osteopathic treatment.
Yes, yeah. It was interesting because I've got an example for you. I was doing a Zoom with an elderly woman in Brazil, her son is an osteopath, but he thought it would be a good idea if she had a session with me, a clinical session. And she has back pain. But because where she lives, it's the weather, and it's difficult to walk outside because she doesn't feel safe. She sits most of the day. She doesn't move very much. And we know that half an hour of walking a day can be as good for back pain as any other exercise or any other medicine. But you need to be aware of those kind of social, environmental factors. And so the treatment has to be patient-centered. It can't be the therapy. So I would want her to go out and I would encourage her, but I can't force her. I can only depend on her contribution to the treatment. So the treatment, in my view, is a team's work. It's not me, you, we are together as a team. We're trying to find a solution to the patient condition. So it's very patient-centered, the whole thing. Also the exercise prescription, as you'll see soon. Yeah.
It's this dyadic relationship between osteopath patient and yes. So you pose very going straight to the book. So the functional exercise prescription. It's your new book. I mean, you have several. 2022. Yes.
And a very proud father.
Yes, and I'm going to show it also on a slideshow, and it's amazing cover. I think it says a lot, that image, and you pose very interesting questions in the book. What is an exercise and how is it different from daily activities? Makes a lot of sense, the question. How do people recover naturally and how can we support it? It's a very pertinent question. What are the differences between acute and chronic pain? Is there a difference in exercise management for acute or chronic condition? What is stiffness, and what is the difference between feeling and being stiff? That's a very interesting question.
Stuff. This thing that what we are learning about stiffness. Yes. There's very little research about it. It's almost non-existent.
Yeah.
So if there's anybody out there who wants to do a PhD on stiffness, talk to me. But it's really an emerging science because it's all been overtaken by pain. We are so focused about pain. Mm-hmm. We forgot all those patients in the clinic that tell us, look, when I get up in the morning, I can hardly move. And so I would say to them, oh, is it painful? And they said, no, it's really, really stiff. Mm-hmm. And I would say, but is it painful? No. And they said, no, it's stiff. And I just couldn't get it into my mind that they have another symptom that I'm not kind of learned to deal with. And that's stiffness, and it's a huge, it's fast problem for people. And as I said, hardly researched at all.
You give me food for thought. I'm thinking about plastic changes in tissues, and I'm thinking a lot about old people. It doesn't have to be old, but older. That the whole movement is the whole dynamic. It's changed because of basically stiffness, not so much pain.
Exactly.
And it's very interesting. It just made my brain go a bit off in the sense of thinking about this stuff. That's amazing. And maybe we can talk a bit.
I think I've given an example in the book. This is really fascinating if you think about stiffness. So amputees have phantom limb pain. We all know that. So they have pain in joints that are not there anymore. But also they have phantom stiffness. They feel stiff in the non-existing joints. And when you ask them to exercise the phantom joint, they become less stiff in it.
Wow.
It's completely brain initiated. It's quite remarkable. You can't get your mind around it. It's really, it just goes, whoa, okay. How does that happen?
Yes.
It's fascinating.
Okay, I have goosebumps.
Yeah.
Is there a rationale overall overall structure for exercise prescription? That's going to be so. My next question, if I may, it's that you not just in this book, but even prior in other papers in other books, you talk about this three primary processes in functional recovery, which is basically where we know about inflammation and injuries, and then basically repair, and then adaptation, and then alleviation of symptoms.
So that's the recovery process of functionality. To recover your functionality, your ability to carry your daily activity comfortably, easily, and efficiently.
Yeah.
And you need those mechanisms. That's what the body does. That's the way it will recover. And it's interesting because it's the basis of osteopathy, actually. One of the tenets of osteopathy, the most basic principle, when you strip everything away, the most basic principle is the person or the body heals itself. Fantastic. But nobody has then asked, well, how does it do that? What is the process by which it does that? So we all go out celebrating that it does that. And from an osteopathic point of view, we do it by biomechanics. We correct the biomechanics and help the body to recover. But actually, it's much more fascinating than that, because there are three dominant processes. Like you said, repair, adaptation, and modulation of symptoms or alleviation of symptoms. And once you understand which process is at hand, the main process, then you can create environments that support this process, and you're doing it through your osteopathy, your handwork, physical, manual therapy, osteopathic, the advice you give to the patient. It's kind of multi-dimensional support. Yeah, so that's a big part of it, and that's how you. The whole exercise, functional exercise prescription, is resting on two basic principles. One, that it's functional, that it's individual, it's adjusted to the individual and their movement and life repertoires. So that's the one thing. And then there's another thing, which is, okay, you've done that. Can you identify the process by which the person is going to recover? So you have to stand behind the patient or in front of them while you're taking the case history. And if they had an acute lower back pain, you need to ask yourself a very simple question: is by which process is this person is going to get better? The moment you can say that out loudly, you know what to do, because the research has been done for us. Medicine, science, everything for the last 100 years, people have been looking exactly at these problems. And so it's well described. And that would be obviously very different from someone who's got chronic back pain, where it's not a repair process, where it's more something to do with the pain mechanism. They've got a pain disorder more than anything else. So, I mean, if you think about the advice that you're going to give someone who's got pain of a chronic pain and patient who got pain of injury, well, in pain of injury, you tell people, well, hold back before you go back to doing any serious activities, because the person has to heal first. Well, if you have someone with a chronic back problem, you can tell them you can do whatever you want. It doesn't matter. You can jump out of an airplane with a parachute, because your back is sensitive. You experience pain, but actually the tensile, the physical strength of the spine is the same as anybody in your age group who doesn't have any back pain. And that's a tremendous message for the patient. It completely changes the way they understand their body and what they need to do and what they can do. So it's sometimes in those simple messages. And so this is, I'm just giving you an example how I would use this model, just from exercise point of view.
Yeah. So it's like, see if I understand it. It's so we have this three primary processes of repair, adaptation, and alleviation, basically identifying which. So you even have a diagram, which really, I can show it later, but we have a diagram of this three processes. So basically identify in which process the patient is and apply the intervention, or think about the intervention accordingly to that stage. Yeah.
So if you have a stroke patient with chronic stroke, and they can't function, they've lost their functionality in some way, then the question, so you stand in front of the patient, you ask yourself, by which process is this person going to recover? They don't have repair anymore because the stroke has happened already, but they have motor changes and so on. And the only way that they're going to recover is through adaptive processes, whole person adaptive processes. And they are very different from treating someone who is in a repair process or for modulation of symptoms.
Yeah,
it's completely different management. Mm-hmm. And that means what you do on the table with the patient or in the room, and then later what the person does themselves will dramatically be different from these two processes.
Yeah. And even so. And indeed, sorry, I was just thinking. Even the example you said about the chronic pain, it's something we see a lot in the clinic practice, which is it's almost like an opposite effect in someone who's more like acute, that sometimes has this eureka moment of, oh, I'm super well, I'm super better, if with a GLA, let's say that something, a crack happens and the patient, wow, I'm so much better, and it's almost like the opposite effect on a more chronic or more worried patient, where is so afraid of doing a specific movement that is somehow settled in his memory program of a certain injury. And sometimes just the comfort of our hands, or just explaining that, you know, the tissues are basically healed and everything's it's just basically is and then just giving this safety, and even going with the patient to that specific movement he fears. And then sometimes the eureka moments happens there, just an active movement of realizing. Yeah.
I mean, surprisingly, with chronic pain, the role of manual therapy, osteopathic manual therapy, is really important. I couldn't get my patients better just with exercise. In fact, we know that if you just concentrate on exercise alone for just pain, the effect size, the clinical effect size is very small, depressingly small, actually.
Really?
Something like 2 points out of 10.
Oh, wow.
That's all. And that, regardless if it's osteoarthritis, lower back pain, neck pain, shoulder pain, it's really, really low. So the osteopathic supplement of the hands-on, the connection with the patient and all that, that's where the magic actually happens, the magic of recovery.
Yeah.
It's not just, I'm saying that because quite often the exercise is used like a hammer. You're in pain, you're in chronic pain, then just do this exercise. And if they don't work, do them harder. And if they still don't work, do them even harder and harder and harder. So just keep on beating the body into some kind of submission, hoping that in some way, by doing this really severe exercise, you eventually can extract the pain out of the body. And it actually does the opposite, of course. That's why people don't maintain exercise regimes. And that's why the whole idea of a functional approach is, look, don't give them exercise. All of life is exercise. All physical activities are exercise. Just get them to do maybe a little bit more of what they're doing in the case of chronic pain.
It's one of the critics you do in the book is actually the limitation of the traditional strengthening and conditioning models in rehabilitation, which is, you know, strength.
That's right. Yeah.
Yeah. And you talk about a lot about daily activities as part of the functional rehabilitation, which you have this sentence which I find amazing, which is all physical human activity is exercise.
Absolutely.
And life is your gym. So that's an amazing statement. And because functional exercise is actually, you know, it can be, as you say, it's in your book, shared activities or unique activities.
Yeah.
It can be anything but, you know, walking or going down steps or up steps or playing sports. And it's really, how do we prescribe, how do we decide it's like tailored to the patient, what he needs, or to what we perceive that it's going to be better for him, or what is?
Okay, it's actually very, very simple. Ask the patient where they want to be. Yeah, ask the patient, and quite often they would wish to be in the same place they were before their condition started. Quite often. So if you ask them, what would you like to be able to do now that you can't do, you haven't been able to do, and they say, oh, I'd love to be able to walk again. I'd like to go up and down stairs. I'd like to get in and out of bed or and out of the car. So what's better than giving them those activities which they find difficult? And the idea is, if you pursue it, eventually you recover it most of the time, not always, of course. There are a lot of caveats here. But most of the time, most people will recover their lost functionality through doing what they can't or unable to do at that time after the injury. And so, and basically what you do is you then construct the management depending on which process you believe they are in, the repair, adaptation, or modulation, alleviation of symptom processes. And that's where a workshop is needed, how to do that. And the book, if you have a look at the book, it has it all there.
Yeah, I'm going to show the book in 5 seconds. I was just thinking, do you because you're very much involved in this neurosciences and rehabilitation. How important is it? It's kind of a side question, but how important do you feel it is in like more complex patients with like you said, sensitization, central or peripheral, with changes that we know in the central nervous system, in terms of catastrophization, less cortisol, and basically autonomic also responses of sensitized and exaggerated. That goes together with emotional responses and the interaction with the external environment. How important is that? Do you include that in the prescription of exercise? Like, this guy really needs to go outdoors and look into the sun, or get some vitamin D and look in the horizon to increase his dopamine levels and boost his sympathetic response, or it doesn't?
So in my worldview, everybody would be walking and having a much better life. In reality, people have habits that are next to impossible to change. And I've tried many times. People who don't exercise just don't exercise. They shouldn't be felt guilt or shamed in any way. It's okay. You don't exercise. You might need to come here a bit more often. That's that kind of choice you give them. But it's I'm treating people. I'm treating someone with a chronic lower back pain now, with severe pain. She got better quite dramatically after a few months, and only to have another flare up in her chronic lower back pain. And she says to me, look, and I say to her, look, we know that walking is so good for back pain. It can really reduce symptoms, just being out and walking around. You don't have to walk very far, just, every hour or 2 hours or 3 hours, get up, go for a walk around the block, or just go for a 10 minutes stroll, and just do it a few times a day. And she says, I can't do it. And not only that I don't do it, in my office, I've got a treadmill by my table, and I never use it. I never get out to walk on it. I just get so engrossed in my work that I just don't do it. And this is the problem that we have. People's behaviors, once they are established, are a devil to change. You can't change them. So what I suggest in the book is we preserve the patient within their environment, because if you can imagine, it's a conglomerate of circumstances that bring the patient to that point in their behavior. It's not that they choose to be inactive. It's kind of their whole life and their present condition and their present circumstances. They might live in a house with without a lift or whatever. So there's a lot of circumstances in that. So within these circumstances, how we can just tweak it a little bit, just a little bit, so they don't have to go out of their way. But usually it's better if it's negotiated, rather than me saying, you need to do that, you need to do that. Try to do it as little as possible. And not to be annoyed with the patient in any way, if they don't, but to accept it, that's, hey, I'm the same. If you gave me an exercise, I just wouldn't do it, no matter how good.
There's an empathy that needs to be established between.
Absolutely, yeah, exactly.
I remember a story about this teacher in the UK. I'm not going to say his name, but and it didn't happen to me. But I remember a story where it's because it's so funny how paradigms shift even though if the questions are the same, but paradigms shift based on the same questions. Very interesting. It's like there was a teacher that really defended this idea of homeostasis, with really depending on the functional. I'm using your word, but depending on autonomous nervous system really balanced. And what he did in the clinic and in the private clinic and in the school was basically stimulate a lot of the sympathetic response to gain a parasympathetic response after. So he really literally frighten patients or be rough or brute or talk roughly to patients.
Okay.
To stimulate then a parasympathetic response. And now we know that how important it is, even the touch or the words or the way we communicate or the way we explain and understand the patient. So it's funny in that regards, because he's really trying to find the inner health. From his view, it was all about the autonomic nervous system and how we respond into into a stress situation, basically. And nowadays we really have to create this connection kind of with the patient, and we know that's really important. I must say that even the way you explain it, the way you talk, and it really feels the way you really respect the patient as a person.
Absolutely. Yeah.
And you can really transmit just by talking to you for 20 minutes. You kind of reach the point where you respect the patient.
Yeah, you see the other as the same as yourself.
Yeah.
In some way, of course. You can't be completely, but they're not really a patient. They're just another person sitting there. And you are trying to help them in some way. And you try to do it as some kind of a teamwork.
Teamwork, yeah.
Yeah, rather than kind of a superior.
That I know
very,
more.
very important is where there's ego falls in.
Yeah.
And I must say, people are attracted to ego. That can happen, charisma and ego, yeah. But I don't know if it really helps the patient in the long term, because ego is all about the therapist themselves.
Yeah.
Yeah.
And there was a paper, I think 10 years ago or something, in Canada, where they with MRI, I think it was functional MRIs, I'm not sure. But basically what they found out was the cracking noise was as much gratificant, was much it stimulate the gratification areas, the reward areas of the brain in the patient, but as much in the patient, in the osteopath, in the applicant. So it was really rewarding for the one who was cracking.
Okay.
And yeah,
so
and it was very interesting because it's almost like you do the cracking not because of the patient, but because you want to have this reward feeling, kind of. That was the conclusion of the study. And yeah, it's one of the things I keep saying. You crack things with high velocity and low amplitude, and you think you're gaining some sort of mobility. And biomechanics of the tissues don't work that way, guys. You're not gaining any mobility with high velocity.
No, you just get a bounce back. It will become a very stiff spring and bounce against you.
Yeah.
That long-term flexibility is a very complicated issue. And there's a lot of research has been done about stretching, as you can imagine. But we know that clinical stretching, not recreational stretching, but clinical stretching is highly ineffective, no matter what technique you use. And that's why I wrote the whole book about functional stretching. And basically, the whole idea of that is that you challenge the end of range of movements within functional daily activities. You're much better off doing that. So, for example, if someone has a gait stride problem, they've got a short and they need to increase it. Now they have two methods of doing it. They can lie on the floor and do straight leg raising to flex the hip. Or you can just tell them, well, why don't you just walk with a slightly bigger stride? Now, if they are good walkers, they would do maybe 5,000 to 10,000 steps a day. So they're doing all this stretching every day, challenging it. And that's probably what you need, this kind of long-term, intense stimulation.
And that brings us back to stiffness a little bit, no? Maybe what we need in, as we age is more than this dynamic. So
there is physical stiffness, but also in young people, people with neck pain and chronic low back pain. So it's probably part of sensitization, feeling stiff, a neurological phenomena of some kind. So it's not just it's not just in the elderly, but more pronounced, I think, as we get older. But surprisingly, there is a difference between range of movement and biomechanical stiffness and feeling stiff. Mm-hmm. They're all different things. It's probably too long to go into the details of that, but there are three things to look at when you look at stiffness. Yeah. Generally speaking, people who feel stiff don't necessarily lose range of movement. Mm-hmm, mm-hmm, mm-hmm. So if you ask a person with a chronic low back pain to bend forward, they will experience stiffness in the hamstrings in their back when they are bending. So the experience compared to people who don't have back pain. However, they have the same range of movement. So if you get a patient with chronic low back pain, ask them to bend forward, they can bend forward as a normal individual. That's a surprising thing. Yeah. But they feel really, really stiff.
That's why they feel so comfortable if we put our hands in the back and if we help them and they feel more safe. And could be that just the nervous system is really protective and it just contracts the muscles not to move forward.
Exactly.
And it makes me think about another study in South Korea where they found out they have a very low prevalence of hip arthrosis and hip degeneration and low back, because in their daily activities they still sit a lot. So basically, the brain is not protective because they're doing their daily activities of going down and sitting on the floor and picking this and picking that. So it's more distracted. That's just I'm just thinking about this. The brain is more distracted.
Yeah, I mean, it could be also genetics.
Yeah.
So kind of to do with this race, but different races maybe have
different genetics.
Because osteoarthritis is not a biomechanical disorder; it's a biological disorder. Mm-hmm. So they might have genetic disposition or not to this kind of illnesses. So there might be differences in populations in that way.
Yeah, but what was fascinating was that this South Korean they felt they felt their bodies really kind of the same way for the past 40-50 years, because they did tai chi, they sat on the floor, and if we think about this chronic conditions, is really like the brain is really focused on the condition itself, and then hence the protection. But as you said, there's a lot of juice there. So I'm gonna show a slideshow, which is your book, the cover, and if you can just give a few notes about this is basically the cover, the whole functional movement dynamics. Congratulations for the cover, and basically you pose a lot of interesting questions which I already talked about, or we've been talking about, and this is the functional repertoire we're talking, this functional approach to exercise prescription, from walking, sit, stand, stairs, playing tennis, and that we have to really center the patient into this activities, right?
Yeah. So I'll give you an example. I had a colleague of mine, an osteopath, had a hip replacement. Mm-hmm. And a few months later passed, and he was very stiff in his hip. He couldn't sit to stand, for example. Mm-hmm. He found it difficult to get in and out of a chair because of the stiffness in the hip. So he called me and he said, what should I do? And so I asked myself, by which process is this person going to get better? And that would be adaptation, because it's a long-term change. And I said to them, the most simple thing what a person can do is sit to stand. Do the activity you can't do, and eventually the body will follow. That's the idea. And he did that, and 2 months later he called me and said, everything is absolutely fine now. I just did a lot of sit to stand from chairs without using my arms to support it and so on. So starting with a higher chair and then lowering further and further. It's really, really simple, straightforward. So basically you choose from the person on movement repertoire the activity that you can amplify these activities in order to support them. In some situation, you want to diminish those activities if they have an acute injury. So it says you need to install a bit of a protective strategy there in the management.
And that's why it's so important to identify acute chronic stages in pain and different stretches.
Absolutely. Yeah. Absolutely, because they're so opposite each other.
Yeah. And this is the diagram it's been shown in several of your papers. This stages of this basically the three primary processes you talk about. Which stage is the patient? You know, the recovery is right in the middle, and then you have the adaptation, alleviation of symptoms, and repair. And this is what we were talking about earlier about, you know, how we interfere in the patient. I don't know if you want to say more about this or.
So I think I mentioned to you before, these three processes have been highly researched in the sciences for well over 100 years, because everybody wants to know how people get better and how we can help them to do that. So a lot of the book summarizes this extensive knowledge using this kind of model to understand. So the book is divided. If you look at the book, I don't know if they can see me.
Yeah. Okay. You have more to your face? Yep.
It's color coded. So one section is for repair processes, to understand repair processes and how to support them. Then the next section is about adaptation processes and how to support them. And then the next one is about alleviation of symptoms and what we can do for alleviation of symptoms. And then there is, at the end of the book, there is also some exercise shown. And this is because people can have a blank mind in clinic. You're there in front of the patient and suddenly you forget what you need to do, what can be done. So this is just kind of a source for ideas to help you along. Yeah, and there's quite a few also examples of conditions that we commonly see in clinic, and what we would expect and by which process we expect them to get better.
Very fascinating stuff, Professor. And I have also exciting news, which is you are going to visit us, you know, maybe by the end of the year, to an on-site course, online on-site. We still have to talk about it, but to really go deeper into these subjects. And because there's not just osteopaths can gain through with this, even physical therapists or even exercise. How do we call it in Portugal? We call it exercise professionals. I don't know the name in English, but people with that work with exercise, personal trainers, and so
it's
on.
open to basically any person that gives another person an exercise or advice about movement will benefit from this course.
Yeah.
It will give them a very nice structure to work with, very simple and very simple for the patient, and give the patient a lot more choice in their own management. Because yes, you can do this exercise, but you can also just walk or go up and down stairs a bit more. So now they have a choice. They're not locked into one thing.
Yeah. And as you said, there's so many people who don't even, they have bicycles and treadmills and whatever, and they have a huge gymnasium on top of the floor, and they don't use it. So the simplicity of the daily activity exercise and the simplicity of the movement that you want to create in the body and in the person, it's amazing. There's something magical about when things become simple, the simplicity of stuff. There's something quite beautiful about that. Okay, doctor. So thank you so much. We've been here for 45 minutes. I don't want to exceed too much of your time. You've been very kind to accept our invitation, and hopefully we see you in a few months.
In November. And I'll be looking forward to it. I used to teach a lot in Portugal, so I'd be very happy to come back.
How long has it been since? a few years, no?
At least maybe 5 years or 6 years. Last time I was there, but I used to go maybe 3 or 4 times a year. Sometimes I used to teach. So I know it quite well. But at least Porto and Lisbon, I know quite well.
And you're quite well known around here. So I guess around the world. You're going to teach soon, no? Also international. You're going to go somewhere in another country.
So I'm teaching in Israel next week.
Okay.
I've got France. I've got several places I'm going. Yeah.
Very good. So thank you so much. Okay.
Thank you.
Thank you.
See you soon.
See you soon.
Bye-bye.
Thank you so much. Bye-bye.